Let's talk about aneurysms. The walls of arteries are built differently compared to veins. Arterial walls are significantly thicker, more muscular, elastic, and compliant than the veins. Arteries are built to withstand the high pressures of blood pumped directly from the heart. So, when a section of the artery wall loses the muscular layers and collagen, this area of the artery lumen becomes weak and bulges or balloons outwards as high blood pressures press against the lumen of that artery. This is called aneurysm. What are the risk factors and the contributing factors to the formation of aneurysm? We have non-modifiable risks, which are basically what we cannot change and we cannot avoid it. For example, age, usually over 60, are more prone to aneurysms. Males are prone to getting a triple A's than females. Family history, genetics, genetic degenerative connective tissue disorder like Marfan's syndrome. The risk factors that are within our control includes the most common cause being the weakening of the walls of artery from plaques or atherosclerosis and hypertension. Those are the main modifiable risks for aneurysms, atherosclerosis and hypertension. Other modifiable factors include smoking, trauma from different sources. Aneurysms are classified in two ways: by location. Abdominal, thoracic, and brain are the major ones. Of course, you can have aneurysm anywhere along the arteries, even in the mesenteric artery supplying the GI tract. And also, they can be classified based on the shape of the aneurysm. Fusiform, as it looks, this fusiform is common, especially in the abdominal and the aortic aneurysms. And then we have the circular aneurysm, which is common with the brain aneurysms. Let's talk about the signs and symptoms. Usually, before aneurysms rupture, the patient may not even realize they have an aneurysm somewhere. Literally, they are asymptomatic unless the swelling aneurysm is pressing on a nerve or something, or they form clots that embolize and causes a PE or a stroke. So, when symptoms occur, they depend on location. In AAA, the patient may present with abdominal pain, back pain, or groin pain, pulsating abdominal mass. If it's a thoracic aortic aneurysm, the patient will report with chest pain or back pain, cough, hoarseness due to the swollen aneurysm pressing on the nerve supplying the throat and the voice box. They may also have difficulty swallowing. For cerebral aneurysms, there's going to be headache and vision changes, dizziness. And for peripheral aneurysms, we can have signs and symptoms like limb pain, pulsatile mass, ischemic symptoms. Once we suspect aneurysm in a patient, the main goal is to put them in a tight blood pressure control. Otherwise, it will rupture. If you see a question about aneurysms and they're asking what's the next priority, it's always a very tight blood pressure control. We do not want that aneurysm to rupture. But if it does, it's considered a medical emergency. Symptoms will appear suddenly when the rupture occurs. Severe pain depending on the location, like if head, chest, abdomen, or back. Sudden drop in blood pressure, signs of shock, loss of consciousness. If it's a brain aneurysm, the patient might report the worst headache of their life. Complications of ruptured aneurysms include massive internal bleeding leading to shock and potential death. If you have an aneurysm because the blood sits in the pocket, it can form clots in there. That clot may dislodge and go into the lungs and cause a pulmonary embolism, or to the brain and cause a stroke. Sometimes aneurysms can cause compression of nearby structures like nerves, organs, and therefore affect their function. Ruptured cerebral aneurysms can lead to subarachnoid hemorrhage, characterized by the patient saying they have the worst headache of their life. The blood gets into the ventricles and mixes with the CSF. This causes a lot of irritation and therefore headache. Aneurysms happen in arteries, and arteries bleed like a gushing hosepipe. So it can cause a huge hematoma in the brain and then therefore push the brain tissue to one side, causing herniation as well as increased ICP. How are aneurysms diagnosed? Imaging is essential because aneurysms are often silent. So common tests include a very quick bedside ultrasound if you find a patient has a pulsating um, lamp around the umbilical area. You probably the doctor will ask for a quick ultrasound to assess and see if it's an aneurysm AAA or not. So first line for AAA screening at bedside is bedside ultrasound. We can also screen with CT scan, especially for ruptured aneurysms. CT angiography or CTA gives detailed blood vessel imaging to locate which artery is bleeding. MRI, MRA for brain or thoracic aneurysms. For patients with history of many aneurysms, they might do angiography just to give a detailed mapping of the vascular system and so they can pinpoint which ones have aneurysms. Medical management of aneurysms is used for small, stable, or unruptured aneurysms. This includes steps to prevent further damage or stress on the walls of the arteries, tight blood pressure control with blood pressure antihypertensives like beta blockers, ACE inhibitors, ARBs to reduce the wall stress from hypertension, cholesterol management. Remember, one of the risk factors is atherosclerosis, smoking cessation, routine imaging every 6 to 12 months for monitoring, especially if the aneurysm is little, it might grow over the years. So you have to be screening every 6 to 12 months just to monitor. Surgical or endovascular interventions depend on the size, location, and rupture risk. Endovascular aneurysms repair with stent graft placement can be done. Open surgical repair whereby a graft is sewn into the place. Also for cerebral aneurysms, it's common to do coiling where coils fill the aneurysm to prevent rupture and more blood from flowing into the swelling. Surgical clipping where a clip is placed at the neck of the circular aneurysm to prevent it from further growing. For peripheral aneurysms, we can do endovascular stenting or open repair depending on the location. What is your role as a nurse in all this? Monitor vital signs, especially blood pressure and heart rate, assess for pain, neurological changes, or signs of rupture. Check for pulsatile masses. Do not palpate vigorously, it can burst open the aneurysm. Monitor peripheral pulses and limb perfusion. Pre-intervention, if they are going for a procedure, maintain tight blood pressure control to reduce rupture risk. Educate patient on to avoid heavy lifting or straining. Ensure NPO status if surgery is planned. Prepare for imaging or contrast studies. Witness consent for the procedure. Post-intervention, monitor blood pressure closely. Avoid hypertension to protect the graft. If contrast dye was used during the procedure or during the CT scan, hydrate the patient to protect their kidneys and flush out the contrast. Assess urine output and renal perfusion. Check peripheral pulses and check incision site for bleeding or infection. Assess for back or abdominal pain, possible leak in abdominal aneurysm if a patient is reporting back pain. Assess for neurological changes for a patient who had a brain aneurysm. If they have a change in level of consciousness, so that means that probably there is a rupture of the brain aneurysm. Patient education. Educate them on the importance of BP control because the main problem here is blood pressure. It's going to pop that thing open. Smoking cessation, recognizing signs and symptoms of rupture, adherence and following up with imaging and medication. Avoid strenuous activity while at home. That's it, guys. Thank you for watching. And if you haven't subscribed, kindly support my channel, share, like, and follow for more content. Thank you and bye.